Ladies and gentlemen, it's my very great pleasure to welcome you to the first SCONA webinar for 2025. Now, SCONA is the Society for CFD, or Computational Fluid Dynamics, of the nose and airway. It was founded to foster collaboration and collegiality between clinicians, engineers, and researchers from around the world. Now, SCONA's first World Congress was held in London in 2018, with subsequent meetings in Chicago, Oklahoma, and Brisbane. But because this field is evolving so rapidly, it's become clear that annual scientific meetings just aren't enough, and we need more opportunities to disseminate and discuss the latest research breakthroughs. So this is why we're now conducting regular SCONA webinars. Now I can see that we have a full house today in the audience with, we had over 100 registrations from across the globe. So welcome one and all. Our keynote speaker will present a 40-minute talk, which will be followed by 15 minutes of Q&A, and will close the webinar exactly on the hour. Now, if you would like to ask a question, please type your question into the chat at any time. And at the end of the 40-minute talk, the moderators will ask the speaker your question. The moderators for today are both myself and my good friend and colleague, Kiao Inthavong. For those who I haven't had the pleasure of meeting, my name's Narinder Singh. I'm an ENT surgeon who specializes in the nose, sinuses, and anterior skull base. I'm the Chief of Otolaryngology at Westmead Hospital in Sydney, Australia's largest hospital complex, and an academic at the University of Sydney, Australia's oldest and largest medical school, with a research focus on CFD and artificial intelligence. My colleague and fellow moderator Kiao is an engineer and an associate professor at RMIT University in Melbourne, and his impact is in the field of biomedicine and health. Kiao specializes in CFD of the respiratory tract with over 150 major publications and more than 6,000 citations, primarily on respiratory modeling using computational and experimental fluid dynamics. And a special thanks to one of Kiao's many PhD students, Brenda, who is the convener and organizer for today's webinar. Thanks, Brenda. So I'll now hand over to Kiao, who has the very great honor of introducing our keynote speaker for today's webinar. Thanks, Kiao.
Thanks, Narinder. It's a great pleasure to have Alister here. So first met Alister at the Chicago SCONA, and it was great to see him and a lot of the US participants who I can see are here in the audience. So it's great to see everyone here. So Dr. Alister Bates is an assistant professor in the Division of Pulmonary Medicine at Cincinnati Children's Hospital Medical Center. He specializes in respiratory aerodynamics using CFD and medical imaging to develop patient-specific diagnoses and treatments for children who have airway and lung diseases. That includes obstructive sleep apnea, cystic fibrosis, and the subject of today's talk is on premature infants. Just a bit of background. Alister earned his PhD from Imperial College London, studying the mechanics of airflow in human inhalation under Professors Dennis Dawley and Bob Schroeder. And his career has taken him from tracking tennis balls at Hawkeye to Formula One aerodynamics at Williams. He's published over 40 peer-reviewed papers, and his research is funded by NIH and Cystic Fibrosis Foundation. So I'm really excited to hear this talk, and you may have seen a lot of his team's work in dynamic airway motion. So this is going to be a brilliant talk, so I'll hand it over to you, Alister.
Thank you very much, Kiao. Thanks for that kind introduction, and thanks for the honor of talking at this first webinar today. I'm joining you from a very cold Cincinnati. It was minus 15 degrees Celsius when I left the house this morning, so I hope it's warmer wherever you are. I'm very jealous of those of you in Australia at the moment. So today, as Kiao said, I'm going to talk about breathing in premature neonates. I thought I'd start with a quick outline of the talk. So what's CFD got to do with premature babies? How can CFD help babies born prematurely? Is it the right tool? I'm going to talk about how we perform CFD in moving airways and why movement is such an important part of what we do in these patients. I'm going to talk about how we can take metrics from CFD and compare them to sort of more normal clinical measurements of respiratory health. So taking things away from engineering units into units that we can use more directly in a clinical setting. And I'm going to finish with some example results and show how we're actually using CFD to aid treatment decisions in patients today and how I think this is going to move forward over the next few years. So I'm going to start by introducing lung and airway disease of prematurity. So babies are now surviving from as young as sort of 21 weeks through pregnancy, so just after halfway through pregnancy. But one of the last parts of the body to develop and be ready to support life is the respiratory system, particularly the lungs. And because these patients take so much care to keep them alive in the first few weeks of life, they often actually get damage from just being kept alive from ventilator injuries and things like that. We call this lung disease of prematurity bronchopulmonary dysplasia. But that's a bit misleading because it's one disease name for many different sort of flavors of disease, many phenotypes to use the clinical term. And that's what I'm trying to show in this image on the right here. So we've got some examples. So these are MRI slices through the chest. We've got the left lung and the right lung, and we're looking axially. That's through this plane here. And in this image on the top left quadrant, we can see this part of the lung highlighted in red. This is fibrotic lung. This is stiff. This may be full of fluid. This is lung that's hard to expand, and that's what's wrong with this patient here. The patient on the next image with the highlighted in blue is almost the opposite. The lung's kind of empty. There's no tissue there. There's no surface to do gas to exchange between oxygen between the gas and the blood. There's just not the tissue's underdeveloped. The lung is underdeveloped. But of course, it doesn't really matter what the lung's like if you can't get any air there. And so what we're seeing in this third quadrant is a tracheomalacia. So we're looking at surfaces of the trachea. We're looking at the back wall, and you can see the pink image here, which represents exhalation. The back wall's caved in, which is what tracheomalacia means. And if the airway's collapsing and we're not getting air down, then, as I say, the lung doesn't matter. There's also a cardiac phenotype or a cardiac contribution to BPD. I'm not going to talk about that in today's talk, but it is something that we're looking at. And so what I want to do is actually identify which phenotype of BPD each patient has, rather than just say, oh, this is a patient with BPD. Specifically, what's wrong with this patient? And one of the reasons for that is the treatment for one phenotype of BPD may actually exacerbate other phenotypes. So for an example, if you wanted to open up the small airways, if you think that the very distal lung is blocked, kind of like an asthma type phenotype, you might think a bronchodilator like albuterol might be a good treatment. But if you give albuterol to a patient with tracheomalacia, that albuterol is also going to land on the trachealis, the back wall of the trachea, relaxing it and exacerbating the tracheomalacia. So the treatment for one of these patients may actually exacerbate this patient, and that's why it's so important to understand the right phenotype. And I'm showing the trachea here, but by airway, these collapses, it's not just tracheomalacia, it could be a collapse of the upper airway, the trachea, the large bronchi, or even the distal airways. Collapse can occur at many different levels, and it's important to know where collapse is occurring in your patient. So the key questions I want to identify is, can we use CFD to identify which phenotype of BPD each patient has? And if we can do that, can we assess treatments? Can we look at how each treatment changes the respiratory effort of each patient? And if we can understand how each phenotype responds to each treatment, maybe we can predict the best treatment for each patient going forward. And when I talk about treatments, I'm talking about respiratory support, weaning from ventilators through CPAP and nasal cannulas through to breathing room air. And I'm also talking about surgical interventions and pharmacological interventions such as bronchodilators and corticosteroids. So how do you compare lung and airway diseases? They're kind of different things. How can you weigh them up? Well, one of them, the measurements I'm going to use throughout this talk is the work of breathing, or you can use the acronym WOB to short form. And it's literally the amount of energy spent per breath. How much energy every breath we take in takes energy to do. And we measure that in joules. And I've said here per breath. Very often I'm going to multiply that by the number of breaths you take per day, or the patient takes per day, just to normalize for patients who breathe fast and breathe slow. So if we do it per day, then it's fair. There are two real components to work of breathing. There's the elastic component. So to fill my lungs, I've got to stretch my lungs, I've got to move my diaphragm, I've got to move my chest wall with all the ribs and things in it. And that's all elastic work of breathing, stretching things. And the second main component is the resistive component. So I've got to get air from the outside world through my nose, mouth, trachea, down my airway tree to the alveoli. And so that's the resistive component. And of course, the resistive component is flowing all the way from the nose down to the alveoli. So we can try and look at that regionally and think about how resistance is, the resistance of the upper airway, the trachea, and the bronchi separately. And I wanted to introduce this concept today because we're talking about the work of breathing throughout this talk, and you'll see, hopefully this will become clear why I chose to talk in terms of work of breathing as we go through. So I'm going to move on to the kind of technical part of this, kind of the method section, if you like, where we really talk about how we do CFD in the moving airways. And this section's kind of really aimed at those people doing CFD. I will come back and talk more about the clinical relevance later, so please don't be turned off if you're not a CFD engineer. So just like anyone else doing patient-specific modeling, our CFD simulations start with getting anatomy from medical images. I know most people, from looking at the literature, use CT. That's great, but with very young babies, we're really concerned about radiation exposure, and so we tend to use MRI. Now, we're lucky at Cincinnati Children's that we have MRI scanner sited within our NICU. That means we don't have to move these delicate babies around. We can scan them right there within the NICU, just wheel them across the hall from their bed. And it is a neonatal specific MRI. So you can see the bore in here would only get about my arm in it, but it's perfectly sized for neonatal patients. Here are some images. So we can see the upper airway here, we can see the epiglottis, we can see the soft palate, we can see the trachea. And just like any other simulation, we have to turn that image into a model. So we do segmentation. So that's basically coloring in where you think the airway is, and you end up with a static model of the airway, which has got all the anatomy of interest that you need, extending in this case from about the nose to sometimes 2, 3, 4 generations of bronchi below that. We just can't see the airways become too small to see in our image. But if it's a static MRI image, we can only get a rigid geometry from it. And that doesn't help us because the airway moves so much through breathing. It moves with the natural movement of breathing, as I breathe in and out. But many of the problems these babies suffer are because they just don't have the muscle tone or the sort of strength of cartilage and things to hold their airway open. So they suffer from, malacia just means kind of soft tissue, but in this terms, it means collapse. So you can have collapse in the larynx, the trachea, the bronchi, or all the way down. Now, there is a CFD approach called FSI, fluid structure interaction, where you make a structural model and you see what the forces on the structure are, the structure deforms, and that's how the geometry moves. To do that, you have to know the tissue properties, and I don't know the tissue properties of a baby's tongue or soft palate or tracheal wall. And even if I knew it for one baby, I don't know how that compares to all the other babies we see across the spectrum of prematurity. And I don't know the neuromuscular control either. So traditional FSI assumes that these tissues are passive, but of course, if you stop breathing, anyone will move their airway to try and open the airway. And that's a very hard thing to get in a structural model. So we take a different approach. We actually try to make our images move. And we do this using what we call gated MRI. So here we can see the result. You can see the diaphragm moving up and down. And we do this just by tracing, as we get each piece of MRI, what the imaging people would call excitation, we're monitoring how was the patient breathing, where were they in the respiratory cycle. So here we've got a sort of 4 respiratory cycles drawn out. And And it's very sinusoidal. So these babies do breathe very sinusoidally. Obviously, with an adult, we breathe in, out, pause, in, out, pause. These babies are much more in, out, without the pause. But for each piece of MRI data that was acquired during the breath, we are grouping them into whether it happened at end inspiration, which I've colored in this sort of light blue cyan color, or end expiration, which is in red, or various other phases during the breath. So I'm taking all the data that we acquired during about an 8-minute MRI, working out how the patient was breathing, and then I can make one image just from the end inspiration image. So what I get is a kind of, over all the inhalations this baby did over 8 minutes, I get an average image of how they were at end inspiration, end expiration, and as many as probably 12 different phases through the breath. So that takes my static MRI and allows me to create an animation from it. You can't do this with all MRI. It has to be a certain type of MRI. I'm not going to go into imaging details for this talk, but if anyone's interested in that, please do put those questions in the chat. So we've now got a moving image. So how do I get from a moving image to a moving surface, which is what I need to do my CFD simulation? Well, we're going to use a technique called image registration, and that's going to literally calculate the motion from the cine, or the moving MRI. I should say this, you can do this all with CT as well if you've got 4D dynamic CT. We just don't really CT our babies very often, which is why I'm focusing on MRI. And so what this registration is we take each frame of that video. Remember, it's in 3D, so 4D with time. But we're looking for every piece of anatomy in one image, and we're looking at how it's moved to the next anatomy. And that's what I'm trying to illustrate with these yellow arrows. So you can see there's a lot of motion going downwards. So you can see around the diaphragm, we can see this motion's moving down. And if we do this for every pixel or every voxel in every image, for every consecutive pair of images through the respiratory cycle, we end up with a 4D map of how each piece of tissue is moving from one image to the next. And we do this with a tool called the Medical Image Registration Toolkit, or MIRTK, which comes out of Imperial College London and is written by Andreas Schuh. If we take that 4D motion map, we can put any point into that map, and we'll see how that point moves through a breath. Well, of course, an airway surface is just a cloud of points. That's what an airway surface model is, an STL. It's just a load of points that make up the airway surface. So if we put the whole STL of the airway surface in, we end up with a moving airway surface. So here I've put in a model that goes from just the vocal cords would be about here. So we've got a little bit of upper airway, a trachea, and main bronchi. And you can see the back wall of the trachea caves in every time this patient breathes out. And that's what we're seeing here. This is tracheomalacia. We've also got a highly dynamic right main bronchus, which is ballooning up with every breath, and actually a fairly narrow left main bronchus too. So we've now gone from our static model to a model of the airway that moves with the real physiological movement that you see in the real patient. And we need 3 inputs for our airflow model. We need the anatomy, which I've already talked about. We need the motion, but there's one other thing we need, and that's the airflow. And we measure that in different ways depending on the patient. We may use a nasal cannula. We may use a flow meter on a CPAP mask. We may, if it's a patient on a vent, we'll put something in line of the vent to measure the airflow. And also we can see the lungs move in the MRI, so we can actually measure the size of the lungs at inspiration and expiration and work out their tidal volume. Lots of different ways, but we can work out what the patient's respiratory waveform looks like. And with those 3 inputs, we get our CFD simulation, and here we are looking at the velocity of airflow going through the airway. This patient doesn't move a huge amount, but you can see a certain amount of motion around where the epiglottis would be, in particular in this patient. So I'm going to get into a few more of the technical details here just for our CFD audience. So boundary condition wise, we're holding the open air at, we set the pressure at the open end. Again, that may be in a different place. If the patient's on room air, we'll put a hemisphere in front of the face, or it may be a CPAP mask, or even an ET tube, which may come all the way down. We'll start the simulation here. But we just hold that end at a pressure that we measure, and that varies with time because we're doing unsteady simulations of a full breath. At the other end, at the distal end of the airway, that's where we set our flow rate. And so we're driving flow from the bottom. I should point out that this isn't over constrained because I'm not setting the pressure at the bottom, so that's still free. So we're setting the pressure here, the flow here, and allowing the pressure at the distal end to be whatever the solver needs it to be to make the equations work. And then we apply our structural model, or rather we don't apply a structural model, but we apply our movement model. As I said, there's no structural model, there's no FSI in the traditional sense, we just have a moving wall. And the way we do that is every node on the wall, so I'm using I to mean the list of all the nodes on the wall, has a position over time, X, Y, and Z. And you can tell I've been in America too long, I'm saying Z. And so we just change that each time. And so what I mean is I'll move to the next one. We run one time step just as you would for any other time step. We then we update the position of every node on the surface. Our solver handles moving the interior node, so we're only moving the surface, and our software handles just through interpolation. It looks at the interior nodes and moves those as they need to be moved. It checks the mesh quality, that we haven't deformed the mesh so that it doesn't work. If necessary, it will remesh, and then we move on to the next time step. So rather than just keep running time step after time step, you have to do a bit of a loop. You solve the fluid, you move it, check the quality, either remesh, or if you're good, move on to the next time step. And that's how we run our unsteady simulations. Some other details for flow modeling: we use large eddy simulation. I'll talk a little bit more about convergence in a slide or two. Second order simulations, as I said, they're fully unsteady. We always do a full breath cycle because we're interested in the dynamics of the full breath, basically. We have a relatively big time step. Again, I'll talk about convergence. These babies breathe very quickly, so this is where we're lucky. Rather than like a 4-second breath an adult would do, we only have to get through 1 second. We have to simulate 1 second of real time to get the inhalation and the exhalation. I know some groups, if they're doing unsteady simulations, will simulate 2 or 3 breaths and take the result of the last breath. We've tested this many times, and we don't really see any difference between the first breath and the third breath. So generally we'll just run one breath. And everything I'm talking about today was solved in commercial package, which you can just go buy, called SimCenter Star CCM Plus. Don't have any relationship with Siemens. I'm not biased towards them, but so anything I talk about, you could do in any of the other solvers just as well. Here are the equations, just to say that the Navier-Stokes equations change slightly. So all I'm going to do is say that in the convection term, where you would normally have velocity, you now have velocity minus grid velocity. So you end up with this minus UG here and here. And there's an extra equation to solve, which is just that you're conserving space. So the flux of the walls of the cell matches the change in volume. I think I'll leave those technical details there. Our mesh is about 5 million cells for a neonatal airway from nose to say second generation. We do have 9 prism layers with a polyhedral core. And this is kind of what it looks like. So these are 3D renderings of some cells, all the cells that attach to one plane. And I like these polyhedral cells. You can see they sort of fill the volume of the airway in this kind of very organic way, and they tend to use less RAM than an equivalent tetrahedral mesh. I think they're pretty standard. You can use polys in most solvers these days. So I want to talk about convergence, and this really answers why did we make all the choices that we've just talked about. Usually with CFD simulations, the way you decide how big your mesh should be, how big your time step should be, is you start with something very coarse and you refine it, and you run finer and finer and finer until the result stops changing, and then you say, well, I've converged. We tend to go a different way for 2 reasons. One is, if you take that approach I just described, you can get stuck in local minima. So you think you've converged, but actually if you'd have kept going even further, you'd got a different solution. But 2, the difference between what we're doing and, sort of aerospace, CFD, or automotive is that we can get the full solution, or get close to a complete solution, a direct numerical solution where we're not making any assumptions. We can get quite close to it without too expensive a simulation. So what we tend to do is do the finest simulation that we can afford to do, and then see if we can match those results with something a bit cheaper. So it's almost like the reverse of a normal convergence study. And I'll talk you through what that looks like. So we did a reference case with a 1/10 of a millisecond and about time step and about 10 million elements. That's not that fine. I know if you look at papers from Barcelona Supercomputing Center and others, people have done over 100 million. But I'll show that actually even these numbers for these neonatal models, and it's a restricted, it's not a very big model in terms of geometric space. We're actually getting pretty close to everything that we need for these neonatal models. The Kolmogorov length scale is the smallest thing, don't worry too much about the maths, but the Kolmogorov length scale is just the smallest flow feature that can exist. Anything smaller than that would just get, through friction, would disappear as heat. So we can actually measure, I'm using the cube root of the cell volume here to measure our mesh. And I'm comparing that to this eta symbol is the Kolmogorov length scale. That's the smallest flow feature that can happen. And on average with these mesh settings, our mesh is smaller than the smallest flow feature. In other words, we're resolving everything that happens in the flow. And if we look at in terms of time, our time step is smaller than the fastest moving thing that's happening. Now, this is average. There are individual cells where we're not resolving fully, which is why I call this a quasi-DNS and not full DNS. But on average, we're capturing all the flow pretty well. And that's our reference simulation. So when we do our cheaper simulations, we're not always doing these fine simulations. When we do cheaper things, our reference simulation is about just over 0.5% different in terms of the results we're interested in. I'm happy to talk about that in more detail if anyone's got any questions about that. And we are going to do some much finer simulations using cloud computing over the next year or so. But for now, I'm going to move on, and hopefully that's convinced you that these simulations are somewhat well converged. So that's how we do what we do. Let's talk about why we do and how we can take metrics out of CFD and use them to assess clinical measurement and to compare with clinical measurements of respiratory health. So why do I keep talking about resistive worker breathing? Why not talk about, most CFD groups talk about pressure loss, or maybe they talk about resistance. Well, the nice thing about resistive worker breathing, we can compare to overall breathing effort. We can actually measure local breathing effort and compare it to overall. I'm going to show you how to do that in the next few slides. So we can calculate the resistive breathing effort over any, just like pressure loss or resistance, over any region. So I might choose the upper airway and say that goes from the nostril to the glottis, or I could choose the trachea, which is glottis to carina, and say, well, how much energy did it take to move air from the glottis to the carina? Every time you inhale, how much energy are you spending moving air up and down your trachea? And I like it over resistance, because resistance, well, I think people assume it's fixed, because in the electrical analogy of flow, resistance tends to be fixed unless you make your resistor too hot. But that's just not true in fluid dynamics. Resistance changes with flow rate. So you can't say someone's airway has this resistance. You've got to take into account how they were breathing. And I think just talking in terms of energy for these babies, we're so worried about their energy expenditure, because any energy they're spending to breathe, they're not using to develop, to grow their brain, to all the other development a baby should be doing. So that's why we choose resistive worker breathing. So okay, I lied. There is another equation coming, but it's simple. Regional resistive worker breathing. So again, we're going to calculate how much energy does it take to move air from the nostrils to the glottis, or the glottis to the carina, so any region that you're interested in. All it is how much kinetic energy is going into a region minus how much kinetic energy is leaving that region. Well, the flux of kinetic energy is just the speed of the air times the total pressure. The other symbol is just because it's the speed of the air normal to the plane that we chose. So if we've got the glottis as the inlet to the trachea, we take the component of velocity normal to that, and the same at the carina is leaving that. So we've got speed times total pressure. That gives us the energy flux going into a region or out of a region. We take the difference between what's going in and out. That's the loss of kinetic energy in the region. And then if we integrate that with respect to time over a breath, we get the energy expenditure in that region per breath. So how much energy are you using just to move air through your nose or trachea per breath? Let's look at that in a real patient. So we've got two patients here, one without tracheomalacia, so a healthy trachea, and one with tracheomalacia. So this is their instantaneous energy loss in the trachea, and you can see it's pretty small in the patient with the healthy trachea. And in the patient whose trachea collapses, it's much higher. And it collapses much more. Tracheomalacia tends to occur during exhalation, and we can see they have this huge effort. It's really, they have to work very hard to exhale. So, and we've done this in 2 models just to show that it's important to have the airway motion. If you have a moving airway, you get this big peak of how hard you're working. And if you have a static model, then you don't get that big peak. And so it's important to have the realistic motion in an airway that's collapsing. And if you want to turn this into one number of how much energy did they use per breath, you just integrate these graphs, i.e. take the area under the curve for the whole breath, and that would tell you the total energy spent per breath. Okay, so that's the CFD part. I said we're going to couple that to existing clinical metrics. So how do we do that? Well, in medicine, there's this concept called the lung pressure volume graph, or a Campbell diagram, and it's simply we're measuring the pressure in the lung and the lung volume, and we're seeing how that changes for a breath. So we're going to start, for some reason, I've started this graph at C. We're going to start down here at the bottom of the graph. So we're about to breathe in. So we're going to make a low pressure. So we're going to move to the left on this pressure x-axis, and we've got volume on the y-axis. So we're going to move to a lower pressure as we inhale. As the air comes in, the lung volume increases. So we've got low pressure and increasing volume, and then we exhale. So we increase the pressure and the volume goes down, and we just go round and round that loop as we breathe. If we, and that's the resistive component. So I said there's 2 components. So that loop that we just drew, the area inside that loop is the resistive component of worker breathing. And if we take the top of the loop and the bottom of the loop and integrate back to the axis, that's an estimation of the elastic worker breathing. There's actually more to it in terms of the elastic worker breathing, but they're hard things to measure in neonates. So that's why this is a slightly simplified version what I'm showing today. So we can measure the resistance, we can measure the elastic component of worker breathing, and all this is based on work is pressure times change in volume. So it's, just work is force times distance moved, but with multiplied by area, you get this this equation. How do we measure this? How do we measure lung pressure? You can't stick a pressure probe in people's lungs. They tend to cough it up if you try. But what you can do is put a pressure probe in their esophagus, and as the esophagus goes through the thorax, it's exposed to the same pressures as the lung. Now, our neonates largely have feeding tubes in their stomach anyway, NG tubes. So if you pull the NG tube back just a few centimeters out the stomach so the tip of the NG tube is in the thorax, you can then fill the feeding tube with water, and your feeding tube becomes a pressure probe. That's how we're measuring this. The x-axis, our pleural pressure, and lung volume we can get just from integrating the flow curve or by looking at the lung volume from the MRI. And all these measurements we're making synchronously in the MRI so that we know exactly how the airway is moving, as we know what the flow rate was, and at the same time the pressure. So all those 3 things are synchronous. So we've now got, from our lung pressure volume graph, we've got the elastic worker breathing and the resistive worker breathing. Our CFD simulation, as we talked about, we can measure these components of resistive worker breathing. And for the purposes of this, I've said upper airway, trachea, and proximal bronchi big enough to show up in an MRI. You could choose different regions if you wanted: nose, pharynx, larynx, whatever, if you wanted. But there's one piece missing, and that's, what about the resistance distal to the airway? Well, if we know the total resistance, and we know the resistance basically from the nostril down to here by adding these 3 together, then the difference between this, the total resistance, and these 3 is the distal resistance. So that's resistance from the bottom of the bronchi that we have in our model down to the alveolar. So now we've got 4 regional components of resistive worker breathing and the elastic worker breathing. So that gives us 5 total components. And this is what it would look like. This is not a real result. I'll show real results later, but this is kind of just an idealized picture of what it looks like. Most of the worker breathing is elastic, and these resistive components are pretty small. So it's much harder to stretch the lung than move air through a tube, assuming the patient's healthy. But what we're going to see is, as you have different phenotypes of disease, these components start to change. So in a baby with an upper airway obstruction, let's say laryngomalacia, that upper airway resistance jumps, and it doesn't jump a little bit, it jumps massively with just a small narrowing, we get this massive increase in breathing effort. And so by comparing the components of breathing effort to what happens in a control, we can really identify which phenotype of BPD each baby has, or sometimes they'll have multiple phenotypes. So the patient we saw with tracheomalacia, they'll have the tracheal resistance component goes up, whereas the other ones stay the same. Patients with hyperinflation, so that's basically distal airway problems which tend to occur on exhalation. They just can't get the air out of their lungs. They end up sort of breath stacking. They'll end up with a high distal resistance, whereas that patient we saw at the beginning with the real stiff fibrotic lung, they'll have this elastic component. It's much harder to stretch that fibrotic lung. So now we've got a way of quantifying and comparing these different components. So this was all kind of how we do it and why we're doing it. Let's look at it in a real patient, because I think that will bring home how this can be useful and why this can be useful. So here's a patient that we MRI'd. This was a neonate, imaged at around term age, for around 40 weeks post-menstrual age. I think they were born at 27 weeks, so 13 weeks old, but equivalent to a normal term age baby. We've already seen their MRI, and spoiler alert, their trachea looks like a horseshoe, which is tracheomalacia. The back wall's caved in. So we'll see if we see that in the numbers. Here's their flow. We're measuring their flow rate at the nose. We're measuring their esophageal pressure. That's this orange curve, all synchronously with the MRI, so everything's synchronized. If we plot or integrate the flow so it becomes a volume curve and plot it against the pressure curve, we get this lung pressure volume loop. We can measure the resistive work of breathing as this loop, and the elastic work of breathing as the integral back to the axis. We do our CFD simulation based on our moving MRI, and we get the airflow. From the airflow, we can get the resistance components in the three regions. And here are the results. So we can see their elastic work of breathing is relatively normal, but normally the resistance would be much smaller. In this patient, they've got a large resistive component working breathing. So they're working really hard just to move air in and out. And if we look at where are they spending that energy, a lot of it is in this part here, which is the trachea. So as I said, they've got tracheomalacia. It's not unexpected to see this effort's gone up massively. Let's compare it to some normals, because we don't have any reference at the moment. So we're expecting this component, and the literature varies quite a lot on this, to be between 200 and 600 for a normal term age neonate, 200 to 600. Well, in our patient, it's 1600, so somewhere between 8 and sort of 3 times higher than normal. And in the trachea, we're expecting it to be between around 60 joules per day is average for a kid without tracheomalacia. This patient's spending 700, so almost 12 times elevated. And we see this all the time, that just a small amount of collapse results in a massive energy expenditure. It's not like, oh, the airway collapsed a little bit, it's just a little bit extra energy. No, it's a small amount of collapse can result in quite a huge change in breathing effort. And this is just one time point, but now we've got this tool where we can assess all these components. Not only can we phenotype this baby and say, well, this kid's got tracheomalacia. If we give this kid a bronchodilator, we're going to exacerbate that tracheomalacia by relaxing the trachea and make it worse. So we know we shouldn't give him that treatment. We can actually compare this patient before and after treatment, whether it's bronchodilator, surgery, corticosteroids, change in respiratory support, and see how these things change. Does his overall breathing effort get better? And if it does get better or improve, where are we making that saving? Are we, if we gave CPAP, maybe that would give a little support to stent the airway open, something like that. If we gave corticosteroids, maybe it would make the lung easier to expand, and this component would reduce. So we've really got a way of measuring a baby's respiratory effort and compartmentalizing it really accurately in a way that we can compare all these different components of their respiratory health with each other in a way that I don't think we've seen before. And we're learning to predict so we can see how that changes, over time or with treatment, with these things, these treatments I've talked about. And with time, we're learning to predict which phenotypes of babies will respond best to which conditions. Which babies can you just leave and they'll get better on their own? Which babies do you really need to do a surgical intervention to treat tracheomalacia, like aortopexy or tracheopexy? When should we wean babies from respiratory support? When should we one of the big questions in the NICU is when should we do tracheostomies and things like that, and we're actually using that in our care today. We can tell which babies are going to need a trach eventually, so we tend to be able to say to families, we know your child's going to need a trach. The earlier we do it, the better, and it really helps us have that conversation when we have this evidence to direct when we need to do these procedures that are so invasive in these young babies. So hopefully what I've done is given you a good overview of how you can do CFD simulations on respiratory gated with real motion, and I've shown that CFD can calculate the regional resistive worker breathing. Again, I've divided it into 3 regions, but if you're interested in different diseases, you may want to break it up into more finely than that. And I hope I've shown that coupling CFD with the clinical lung pressure volume graphs gives us a way of assessing why and where a patient has respiratory distress. And these measurements, as I say, are helping us treat neonates today, or guide treatment, I should say, in our NICU today, and allow us to really understand the risk-benefit reward of any particular treatment on each specific patient and phenotype. And the last thing I want to say in terms of my conclusions is nothing I've said today, although I've talked exclusively about neonates, nothing about the method is exclusive to neonates. You could do this in an elderly COPD patient who's also got, a compressive goiter or tracheomalacia, which also occurs with COPD. You could do this in an asthma patient who's also got obstruction. You could do this in a patient with medialized vocal cords and an A-frame stenosis. Any patient who's got multiple levels of airway or lung problem, we can compare them, quantify them, and identify which one is causing the problem and therefore should be the target for treatment. So that brings me to the end of my talk. I want to finish by thanking my group. The majority of our neonatal effort has been led by Chamindu Gunatilaka. He's done. If you're interested in what I've said today and how we use these tools to assess respiratory health, look for his papers, because he's done a lot of work on this. A lot of our methods and our other research in sleep is led by Chiwei Zhao, and Hamadeh Hayati leads our particle work, and we're interested in if we're giving inhaled drugs to these patients, how those drugs travel through the airway. We also have a huge amount of support from our PhD students, Chris and Kaylin. I should thank my funding sources, the NIH and our own research foundation, and of course all our clinical and imaging colleagues and collaborators who I've listed here. Without any of these people, we wouldn't be able to do the work that we do. And of course, when we're imaging these babies, they need a huge amount of clinical care. So thank you to their care teams for letting us do all these experiments on their delicate patients. So that's my talk for today. Thank you all very much for listening. And with that, I'll hand back to Narinder and to Kiao.
Well, fantastic. Thanks, Alister. Ladies and gentlemen, I'm sure you're all just as impressed as I am with that wonderful presentation. All right. Thanks, Alister, and thanks, Kiao. So, look, well, ladies and gentlemen, as much as we would love to continue this discussion, unfortunately, it's now almost 8 a.m. here in Sydney, and I do have to get to the operating theatre. Now, again, Alister has very kindly provided his email address for you to continue the conversation. So please do remember to subscribe to the SCONA mailing list so you can register for our next webinar. And if you'd like to present a SCONA webinar yourself, please do contact the Society. So on behalf of the panel, thank you all for attending. And depending on where you are in the world, good morning, good afternoon, or good night. Thank you.